A middle aged man presented to me with a pain in the right flank. He had a stone in the right mid ureter that is stuck in the mid part of the urinary passage linking the kidney to the bladder, and few non-obstructive stone in the right kidney. So we have begun the procedure by introducing a camera which we call as URS into the right ureter, and you can identify this yellow thing. This is the stone. Once the stone is identified, then we are now using holmium laser to convert the stone into small fragments as well as into dust particles. This part of the surgery is known as laser URSL. So the objective is to break this stone into fragments, to extract few fragments into the bladder, if possible all the fragments of the stone into the bladder, and if not possible to pump the fragment up into the kidney, which can be later dealt with RIRS. You can see this is the coating of the stone, as if I am making a hole inside the stone. So this holmium laser is basically used very meticulously in the ureter, because the ureter is a closed lumen. It is a closed structure with hardly any room for error while using laser. In this we use a frequency of 5 Hz and a energy of 1 joule. So we are slowly breaking the stone into smaller fragments. We also assess whether the stones can be extracted into the bladder. This white kind of cloudy thing you can see in the camera is basically the dust particles, as well as the pent up pus and the pent up urine, which is now making its way down from the kidney, which was obstructed because of the stone. Why it is so important to use laser meticulously in the ureter is because if the laser fiber touches the ureteric wall, so there is blanching. Blanching means that part of the ureter wall becomes whitish, and it is just like ureter getting burned. So anything which get burned later on, there is a compromise in the size of the lumen. So there is a chance of development of a ureteric stricture later on. So we are very slow. We are fragmenting the stone intermittently, firing the laser. We are not rushing into it. Unlike the RIRS performed in the kidney, where we still have room in the pelvis or in the calyces, it is very, very, very important to perform laser surgery very, very meticulously, especially in the ureter, starting from the pelviureteric junction to the vesicoureteric junction. Now that the stone is fragmented into smaller pieces, we are trying to further fragment the stone into pieces small enough to be extracted into the bladder. There is no fixed setting to the laser. With every move, we continuously change the setting. Like we continuously decrease the energy from 1 to 0.8 or 0.6, depending on what exactly is our final outcome that we are hoping for. The person who is providing the irrigation with the normal saline is a scrub sister, She is quite experienced. You can understand this because when I am firing on the stone, she knows how to, or how much amount of fluid to be pushed inside, because there's always a chance that if she pushes the stone, or if she pushes this normal saline uh, fast or slightly with a more force, this stone may go back into the kidney and may also miss my laser target. So it comes with experience of several cases. So you can see this is small fragments of the stone now. That stone which was stuck in the mid ureter has been converted into multiple stones. You can also appreciate few dust particles present on the ureteric mucosa or the wall of the ureter. This is a ureteric uracil tri-prong forceps. You can see this is a tri-prong forceps which we are using to remove the stone. The stone was big enough. We could not in the initial attempt we could not bring it back to the bladder. So we needed to fragment it further. These small fragments that we will bring to the bladder, this does not require retrieval. Once the catheter is omitted the next day of the surgery and the patient passes urine, this will easily pass off, and sometimes even the patient doesn't even notice it. Laser fiber is again introduced to break this fragment into further smaller pieces. So you can appreciate this fragment has been extracted into the bladder. We are again entering the ureter. So this will now be a repetitive process. Yes, extracted and left in the bladder. The stone that you are visualizing in this URS is magnified by almost 10 times. So you might feel that is big, but it is not actually big. But yes, we need to extract it. That is why the aim is to further convert it into smaller particles. We're using laser. You can see the firing of the laser is very meticulous, but even with every firing there is a displacement of the position of the stone. So this has to be done in such a way that the ureter is away from the line of firing of the laser. So to put it once again, that this patient had a right flank pain. Now because of the stone in the lodged up in the mid ureter. Also there were one small stone, one or two small stones in the right kidney. So the pain that the patient experienced is because of this mid ureteric calculi. He wished to have a whole right side cleared of all the stones. So he was explained that this can be done provided the caliber of the ureter is wide enough for me to introduce the flexible ureteroendoscope. We haven't yet checked the caliber of the ureter. We'll first deal with this mid-ureteric calculi totally, and then we will assess the caliber of the ureter using the same URS. As you must have checked from my previous videos that the caliber of the flexible ureteroendoscope or the instrument that is used for RIRS is even smaller than the riffle of a ball pen. But still, there are people who has the ureter caliber narrower. We are still in the lower to mid ureteric region, so we haven't yet checked the whole caliber of the ureter. We need to go up to the upper ureter at least, and to feel whether the ureter caliber is distensible and accommodative enough. If it is not distensible or accommodative, then as explained to the patient, we always put in a stent. We remove the stent after 2 weeks, and then we go for the RIRS after 2 weeks. But in this, see, we have almost cleared the stone of the lower ureter. Few stones may have retropulsed or may have pushed back into the kidney because of the normal saline or the irrigation fluid that is being used during this procedure. So now that we are almost done with the mid-ureteric stone, now our focus will shift towards the stone in the right kidney. See, we have introduced this guide wire, and we'll now follow this guide wire, and we are going up. So you can appreciate the dust particles. We are going up towards the kidney, and there's a few mucosal folds of the ureter. One has to be very careful because it is very easy to injure this part of the ureters. So we are assessing the whole ureteric lumen. You can appreciate that the lumen is almost clear. Yes, it is fully cleared of stone, and you can even appreciate the area where this was the area where the stone was stuck. It is red. See, this is the area where the stone was stuck. So that is the reason it is red. It is edematous. This is the reason why we put a stent at the end of the surgery, so that this area doesn't act as an obstruction to the flow of the urine. So we have introduced the guide wire again, and we'll travel again back up to the kidney. See, you can appreciate few dust particles coming towards you. These are mucosal folds, has to be negotiated very carefully, and this is the kidney. Now we have seen that the ureter was quite accommodative and distensible. We have introduced this ureteral access sheath, and now this is the flexible instrument with which flexi we have reached the kidney. This is the callus. You can appreciate the stones. These are very small stones. This is hardly even appreciable on the X-ray. This is one of the stone fragments we have identified, and this is inside the kidney. We are checking all the calluses of the kidney, and now we are using the holmium laser. Now, unlike the ureter, we can use high frequency and high energy as well to convert the stone into dust particles or into small fragments. You can see the stone being converted into small dust particles. You can appreciate when I'm firing the laser. You see the dust particles coming towards the camera. This process is known as painting the stone. We are actually painting the stone. You can see the surface becoming eroded because of this laser fiber. The firing of the laser, you can see we are slowly eroding into the stone. Few processes like microchipping, dusting, we are using energy of around 1 to 1.2 joule and a frequency of around 12 to 10 to 12 hertz. Here we don't need to worry about any injury to the pelvis leading to stricture. No, we are quite away from the pelvic junction, and we are continuing with the laser process. The ultimate objective is to convert the stone into smaller dust particles or into fragments. So you can appreciate the dust particles coming towards the camera. See, we are continuously trying to push the stone into a particular callus, because once we have done that, then it becomes easier for us to fire this stone. Now we have kind of entrapped the stone in the middle calyx, and now with high energy and high frequency we'll do popcorning of the stone, also known as like, just to give you an example, like we have seen the popcorn, which because of the heat it pops up and down. The same thing that happens with the stone. Can you see there is if possible I'll show you, there is some whitish patch over the calluses. These are called renal plaque. That means this patient, see, you can see in the bottom half of the picture there is some whitish patches. This are called renal plaque. You can see now properly. Yeah, so this is called renal plaque. That means the patient has a tendency to form stones again in the future, so he has to follow the restrictions properly. He also has stone in the other side, that is in the left kidney, which at this very moment does not require any intervention, but the patient needs to have a regular fluid intake of at least 3 to 3.5 liters per day. You can slowly appreciate the stone being converted into smaller fragments. These small fragments or the small dust particles, they easily come out through urine. Few small fragments, they stay in the kidney, very small, because maybe they don't find the space enough beside the stent to come out. So, but once the stent is removed, they also make their way out. So I always tell my patients, once the stone is removed, try to drink more water in the next 3 weeks, because that is the time when even the smaller fragments which are there in the kidney, which they also make their way out. So here we are using extremely high energy, high frequency. We can appreciate, when we are operating, there is outflow of the fluid. This outflow of the fluid is quite warm. And another most important thing is, and you can see the whole kidney is stable. It means it is not moving. Ideally, the kidney moves because of respiration. But here comes the role of the anesthesiologist. Uh, when we start with RIRS, when we have reached beyond the pelvic junction to the kidney, we always ask our anesthesiologist. In fact, now we don't even ask. He knows what I'm going to do. So he decreases the tidal volume. Sometimes even he makes the patient's apneic. So that helps us to target the stone to finish off our job as fast as possible. These are extremely small fragments, extremely small. Sometimes even not visible even on C-arm. You can see the image. It is so beautiful. It is clear. So this is a flexible ureteroscope, and this is a digital one. It is unlike the non-digital ones. Uh, this scope has camera placed at the tip. As a result, the image quality is wonderful. And one another thing is that this whole instrument is basically disposable. It all depends on how meticulously, how properly you are using the scope, how properly you're keeping the scope after surgery, because these are very delicate. uh, these are not reusable scopes. But in Indian setup, as we all know, that we have to use the scope uh, on few patients when we open the first scope. You know why? Reason is that because each scope cost 1 lakh rupees, even sometimes even more than that. So it becomes very costly on the part of the patient, that even if the scope, if this instrument cost 1 lakh, just a scope, so the surgery cost will go up to 1 lakh 50, 1 lakh 60,000. That's not possible. And even the insurance companies also don't reimburse the patient to that level. So that is the reason we try to use it on at least 2 or 3 patients. But after that, what happens is that there is, since these are basically disposable scopes, so the quality of the vision, also sometimes the reflecting mechanism of the scope, they are compromised. That makes the whole RIRS surgery a bit costlier compared to its counterpart, like PCNL, which can be done with reusable instruments. This laser fiber that you can see, this laser fiber uh, cost 55,000 rupees, just the laser fiber. So just to cut the long story short, RIRS in itself is costly. Now different companies are coming up with different scopes which they claim can be used multiple times. They just claim. See, here you can appreciate this whitish patch on the calyx. Can you see on the right side, just below? Yeah, some whitish patches below. Yeah, like chalk. You see, it's more clear now. So these are known as Randall plaque. As I said, Randall plaques means this kidney or this calyces has a tendency to form stones in the future. Very important for the patients to follow the instructions so that the chances can be minimized. If I go by the book, they say that even if you follow all the rules, all the regulations, there is 26% chance that you will develop stone in the next 5 years. That means 26 patients out of 100 will develop stone, no matter how small, 1 mm, 2 mm, in the next 5 years. And 50% of the patient develops stone in the next 10 years. But the positive part is that 74 people don't develop stone in the first 5 years. These are the people who really follow the rules, they follow the instructions. We are almost done with the fragmentation of the stone and conversion of the stone in dust particles. You can hardly find any bigger particles. The particles that you can see now, this particles, these are extremely small, extremely small. We are further firing the laser. More or less the objective of the surgery has been met with. You can see this small fragment that will easily come out through urine. You can see the dust particles. Appreciate the dust particles there. Yeah, see the dust particles, they are moving with the irrigation fluid. Now you can appreciate, now anesthesiologist now again bringing back the tidal volume to normal. You can see the kidney moving now. So we are now coming out from the kidney. Whole ureter looks wonderful. You can appreciate now that we will just withdraw the scope out from the ureter. We are withdrawing back now. Wonderful ureter. Absolutely fine. Absolutely clear of all the stones. These are dust particles, will easily come out. We have now entered the ureteral access sheath. Thank you so much.